Hi, so non-epithelial tumors of oral cavity. First, we'll deal with benign tumors of connective tissue origin. Okay, first is oral fibroma. Oral fibroma is a true fibroma which is very, very, very rare, seen obviously in oral cavity. Uh, it is a reactive lesion which behaves like neoplasm. Okay, irritation. It is also called as irritation fibroma, rheumatic fibroma, focal fibrous hyperplasia, conventional fibroma. Okay, these are the terms can be used interchangeably. Irritation occurs here, traumatic, focal fibrous hyperplasia, conventional fibroma. Reactive lesion है, but which behaves like neoplasm. It's a reactive lesion which behaves like then fibroma, true neoplasm of fibroblast. Fibroma is a true neoplasm of fibroblast, very very rarely seen. Okay, reactive lesion is more common. So difference between reactive lesion and neoplasm is reactive lesion has limited proliferation potential. Okay, fibroblast proliferating, and then it will stop proliferating at when after reaching some point. But neoplasm unlimited potential for proliferation even after the removal of stimulus. Okay, it will even after the removal of stimulus it will proliferate if it's a neoplasm. Okay, fibroblast proliferating mimicking fibroma, oral fibroma. Okay, reactive lesion, it will mimic fibroma. Most clinical features are most common benign soft tissue neoplasm in oral cavity. Fibroma is okay. Then present as a swelling mass growth nodule whose surface is covered with the normal colored mucosa. Surface gets traumatized, ulcerated, painful with the blood, with presence of blood. Blood vessels may be present or not. Okay. Presence of as a swelling mass growth or nodule, most common benign soft tissue neoplasm in oral cavity whose surface is covered with normal colored mucosa. Normal colored mucosa. Okay, surface get traumatized, ulcerated, painful, painful, bleed may be present or not. Most common side in buccal is buccal mucosa, seen along occlusal plane. Okay, if the buccal mucosa comes between teeth and the line develops linear alba type. So fibroma will most common place. It will occur there. Seen on lip also, after buccal mucosa, labial mucosa also, floor of mouth also, and tongue anywhere in the oral cavity. The treatment, histological features are bulk bundle of collagen fibers are present. Okay, fibroblast, increase activity of fibroblast. Fibroblast have fusiform shape. Okay, like this. And mature fibroblast is known as fibrocytes, which are spindle shaped. Okay, then thickness. This is the histological feature. Slide type I've done as any diagram. Decreased thickness of epithelium and flattened epithelium, connective tissue interface. Okay, no rete is present. Okay, so also called as atrophic epithelium. This is the differentiating factor. Okay, treatment is simple surgical excision before ulcer. Okay, if ulcer is present, then remove the ulcer first. Treat the ulcer first, and then simple surgical excision. Then now fibroepithelial polyp. Fibro means epithelium. Epithelial means connective tissue. Polyp means growth. Epithelial connective tissue growth. Fibroepithelial polyp. I have made this diagram. It's present in front of mandibular anteriors. Okay, sites of trauma, gingiva and buccal mucosa are commonly involved. Etiology is fibroma, constant source of trauma. Etiology is constant source of trauma. Okay. Then inflammatory response occur there where there is constant source of trauma. Then proliferating in epithelium plus fibrous connective tissue. Epithelium proliferate and then fibrous connective tissue is present. Fibroma occurs, increased thickness of epithelium, hyperplastic epithelium, same. Ratted edges are present. Okay, long ratted edges are present. Same as oral fibroma. Okay, just ratted edges are present. Okay. Mm. Inflammatory responses are proliferating epithelium, fibrous connective tissue, hyperplastic epithelium. There it is. Atrophic epithelium. This is hyperplastic epithelium. Then giant cell fibroma. Giant cell fibroma. Papillary surface. Okay, so not associated with it is not associated with trauma. Most common site is mandibular gingiva. Histopathology is bulk is made up of collagen bundles. Bulk is made up of collagen bundles. They are interspersed with giant fibroblasts. These are giant fibroblasts. These are small giant fibroblasts, and these are big. Stellate shaped plus multinucleated fibroblasts. Atrophic epithelium is present, but have long and thin, rated edges. Okay, these are seen in stellate shaped giant fibroblasts, seen at periphery, not center. Then peripheral ossifying fibroma, peripheral cementifying, also called as peripheral cementifying fibroma. It's a reactive lesion, removal of stimulus. It's a reactive lesion, removal of stimulus. Growth stops after this. It's a reactive lesion, not a neoplasm. Okay. Growth stops after. Okay, proliferating. That's the meaning of reactive and neoplasm. This is the, peripheral ossifying fibroma. Most common site is gingiva. Then anterior is most common than posterior gingiva. 80% is present in gingiva, where most common source it is because of peripheral ossifying fibroma. Most common source is calculus and plaque ossifying cementifying. It is extra osseous lesion, not intraosseous, not inside the bone. It is outside the bone. It's a soft tissue lesion. All the peripheral lesions are soft tissue lesions. All central lesions, centrals are intraosseous lesions. Okay, remember this. Inside the bone, intraosseous are central. Inside, central. Okay, extraosseous are peripheral. Okay, extraosseous lesions which have cementum like and bone like area are present. Histopathology background of fibrous connective tissue, presence or plus presence of calcifications, trabeculae bone like calcification, cementum like calcification, and dystrophics associated with dead cells. Dystrophic calcifications. Then treatment is simple surgical excision plus scaling and root planing. If not done, so increase the if scaling and root planing is not done, then it will increase the chances of recurrence. Okay. Then central ossifying fibroma. Okay. Central cementifying fibroma, it will be an intraosseous lesion. Okay. Central cementifying fibroma, central ossifying fibroma. It's a neoplasm and not a reactive lesion. It's a neoplasm and not a reactive lesion. Okay. And peripheral, it was a reactive lesion, and this is a neoplasm. Here fibroblast get metaphasia, metastasized into osteoblast. Fibroblast, soft tissue, get metastasized into osteoblast, and then it will be like bony tubercle or cementum like calcifications. Intraosseous lesion, not peripheral, and histological features are background of collagen bundles, In this first trabeculae or cementum-like spherules are present. These are the spherules. These spherules have cementum-like spherules. These have brush border fused with connective tissue. Trabeculae-like are these osteoblasting rimming. Osteoblast cells are making the boundary of this trabeculae. Brush border fused with connective tissue. Treatment is resection and prognosis is good. Resection because it's a neoplasm. Okay. Then difference between it's slightly similar, like because the Chinese pattern appearance of histopathologically, it's similar to fibrous dysplasia. It's a developmental anomaly. It's a central ossifying fibrosis and neoplasm difference. Okay. Irregularly Chinese letter pattern are seen in both, but very more common in fibrous dysplasia. Not well circumcised. Fibrous dysplasia is not well circumcised, fused with normal edges and bone. So curettage in pieces of fragments. The line between the normal bone and the diseased bone in fibrous dysplasia is not well defined. So curettage we do in pieces. Okay, and here it is well circumcised, so clear demarcation between lesional bone and normal bone. So we do in toto or in chunk or mass excision. Okay, resection. Then it's a homogeneous pattern of calcification. This is a heterogeneous pattern of calcification, cementification or ossification.